Hello, everyone. Hello, and welcome to the National Health Equity Grand Rounds. I'm Emily Cleveland-Manchanda, the Director of Social Justice Education and Implementation at the American Medical Association and an emergency physician at Boston Medical Center. Today's event, Creating the Conditions Vital to Health, Healthcare's Role in Economic Progress, is being hosted by Rush University System for Health. We are so glad to be here in Chicago at Rush University Medical Center. It's a nonprofit academic medical center that is a national leader in patient care, research, education, and community partnerships. Rush has a longstanding commitment to excellence in health equity. They put this question, who gets the chance to be healthy, on one of their buildings last year to help grow the understanding that everyone deserves the chance to live their healthiest life. For those of you joining us online, welcome. For those of you in the room, welcome. This is the 7th event in the National Health Equity Grand Rounds series, which has been developed by the AMA, the National Center for Interprofessional Practice and Education, and Disability Belongs. This series is a platform for critical national conversations about complex topics in health. It's designed to illuminate the root causes of present-day health inequities by tracing the social, economic, political, geographic, and environmental realities that shape opportunities for health in the United States. It's also meant to elevate the leaders and ideas that shape those opportunities across the nation, bringing forth collective solutions. We have many collaborators in this series, each of whom is working to advance health equity in their own communities. We'll begin today with a land and labor acknowledgement that you see here before you. We acknowledge that we are living off of the stolen ancestral lands of Indigenous peoples, which they have cared for since time immemorial. Today, if you're here in person, we're gathered on the ancestral and contemporary homelands of the Ochakthee, Shakowin, Miamia, Kaskaskia, Peoria, Potawatomi, and Kickapoo peoples. We also acknowledge the extraction of brilliance and energy and life for labor forced upon people of African descent for more than 400 years. We celebrate the resilience and strength that all Indigenous people and descendants of Africa have shown here and continue to show worldwide. We carry our ancestors in us, and we are continually called to be better as we lead in this work. We also want to note that our speakers today have been invited to share their own individual perspectives. The views they express are their own. In the interest of open and respectful dialogue, the National Health Equity Grand Round Series may include speakers whose views differ from the official positions and policies of some or all of the organizations that put the series together. We invite you today to join with an open heart and an open mind. Before you now are the learning objectives for today's conversations. None of our speakers have any conflicts of interest to disclose. Health professionals may earn CME or CE for their participation in today's event, and we'll share those links after the event. I also want to acknowledge our graphic recorder, Rio Holiday, who you see here on the screen, who will be working in the background to create another beautiful visual recording of today's conversation. That image will be shared with participants after the event. And so we begin this conversation today with the understanding that health outcomes are produced not just by our genes, our behaviors, or the healthcare that we have or lack access to, but rather also by the food that we eat, the air we breathe, the work that we do to support ourselves and our families, and the environments in which we live. In fact, we know that 80% of health outcomes are determined by factors outside of the walls of healthcare and genetics. If 4/5 of our health is driven by these factors outside of what Western science and medicine might traditionally consider healthcare, then what role do we have as physicians, as allied health professionals, or health system leaders to improve the health of our communities? Can we do this by ourselves or directly? And if not, with whom do we work? As you'll hear in a moment from our keynote speaker, the Vital Conditions framework offers a powerful way of understanding the many factors, including health and healthcare, that contribute to thriving, vibrant communities. The framework provides a scaffolding for bringing people together across sectors to work in interdependent and mutually reinforcing ways to improve the conditions in which we live. Today's conversation will focus on the ways that health systems can, and in fact are, working to improve the material conditions of the communities that they serve. From Boston to rural South Texas to Chicago, we're going to hear about how they're creating pathways for economic mobility and helping to break cycles of poverty across the country. I now have the pleasure of introducing you to our keynote speaker, Dr. Ruth Thomas-Squance, who is the co-executive director at the Build Healthy Places Network. She is a passionate public health change agent who brings over 20 years of experience working in multi-sector collaborations with diverse partners to promote health equity. You can find her full bio online, and so in the interest of time, I will turn the floor over to Dr. Thomas-Squance.
Hello, everyone. Okay, let me just do my little adjustment here. Thank you so much to the organizers for the invitation to join you today. And the honor, really, of laying the groundwork for what is going to be an amazing panel to follow. So my name is Ruth Thomas-Squance. I'm the co-executive director at Build Healthy Places Network, and we're a national center that works at the intersection of community development, public health, and healthcare to try and transform the way these sectors work together to increase investments in community that address those social drivers of health and focusing on community-owned and community-led solutions to those problems. So I'm going to talk a little bit today about a systems approach to health equity. Oops, I almost forgot my slides. Here we go. I'm going to talk a little bit about a systems approach to health equity, and then we'll ground our conversation in those factors that are upstream of clinical delivery that affect health, and point us in the direction of upstream investments, and also the necessity to form partnerships as a key to success. So when we talk about achieving health equity, and I mean achieving opportunities for everyone to be able to have their highest level of health, we must get honest about what we actually mean by health equity. And we've often adhered to a model that thinks of health as the absence of disease or infirmity. But what if health means something bigger? What if it means people thriving, not just surviving? So then we've got to zoom out. Well, we have to expand our focal length to think beyond the clinic walls with everything else that acts to determine whether someone gets to live their best life. So here's what is exciting. So when we do that, when we invest in those community factors, we augment our capacity to help one patient at a time by creating conditions that support health for everyone in that community. And then that's the difference between treating illness and building health. And it represents a shift from healthcare to health creation. So now here's where it gets interesting, I think. So to tackle this issue, we need to have a systems thinking approach. And this systems thinking is basically admitting that the world is messy and complicated, and that's exactly why this works. So instead of looking for one magic bullet, we'll look at how all these factors interact with each other to create the outcomes that we see. And because if our goal is real health equity, we have to identify and dismantle the systems that are actively suppressing people's ability to be healthy. And the tricky part within a system is that for every action we take within a system, there's going to be consequences, and some we plan for and some we don't. So, for example, if every time we might build a new clinic, but we're not addressing housing, or if we're treating diabetes, but we're not tackling food deserts, every time we sort of focus on individual behavior while ignoring systematic barriers, we may not just be missing opportunities, but we might be making things worse. So that's why I think systems thinking isn't just a nice to have, I think it's essential. Because good intentions without systems thinking can perpetuate the very problems that we're trying to solve. So we know that health happens in neighborhoods. We know that people get sick because of their social and physical environments. And in the same way, good health can be facilitated by assets in the community, such as good quality schools, jobs with benefits, reliable transportation, and quality affordable housing, and so on. So when we start talking about a systems approach, all these interconnected factors affecting health, like jobs and neighborhood conditions, quite frankly, it can get easy to feel overwhelmed. So where do we start? So we need a framework. And that's where the vital conditions of health and well-being comes in. It was created by our friends at Rethink Health. And we at Build Healthy Places Network adopted this framework a couple of years ago, and we have found it very helpful, especially in communicating to our partners in non-health sectors to discuss how their work is actually impacting health, for them to be able to see themselves in that. So how many of you are actually familiar with this? Has anybody seen this? A couple? Just a couple? Okay, well, you can bear with me. I'm going to bring us all up to speed. So with this framework, sort of instead of health people talking to other people about health things, this holistic framework really shows us exactly where other sectors may already be working on pieces of the puzzle. So there's 7 domains composed of community-level factors. We've got the thriving natural world, basic health needs for health and safety, that includes clinical care, humane housing, meaningful work and wealth, lifelong learning, reliable transportation, and then this core domain of belonging and civic muscle. So and if we take one of those domains like humane housing, there are indicators within that which would be things like talking about safe and stable places to live, complete streets, home ownership, and that kind of thing. So suddenly then we're not just talking about medical professionals, we're talking about housing developers, city planners, maybe even the transit authority. So one powerful thing that I like about this framework is that it makes spatial justice visible, because we can actually map exactly where vital conditions for health and prosperity exist and where they don't. And those maps really reflect structural racism or rural disinvestment or the marginalization of tribal communities that have systematically limited opportunities for certain populations. So the legacies of policies like redlining created patterns of chronic underinvestment that really persist today. And this is the essence of spatial injustice. But what has been designed can be redesigned. And we've got an opportunity, really, to ensure all communities have access to the building blocks for health and economic security. So this framework can show us the levers, opportunities for alignment across sectors, and ways that we can steward change to increase our collective well-being. And that's basically systems thinking in action. So it's not only understanding the complexity but it's about finding places where we can intervene to work together across sectors to impact community health. So when the vital conditions are disrupted through disinvestment or other things, communities enter a costly cycle. People struggle. They require more expensive interventions, resources get depleted, and so populations become increasingly vulnerable to unexpected crises, much like the pandemic that we just lived through. So it's another example of spatial injustice becoming visible. So at BHPN, if you think about what does this mean for individual choice? Because we do love talking about health choices in healthcare and public health. So an apple a day keeps the doctor away. That's the classic, right? But what if you have to take 2 buses to get to a grocery store after working multiple minimum wage jobs for your apple? Then we need to have a different conversation. We need to consider what are reasonable expectations of those healthy choices under those circumstances. And when choice isn't the problem, but it's the conditions that make the choice possible, that's what we need to fix. So we've known for some time that your zip code matters more than your genetic code when it comes to your health. But the problem is that gap is getting wide. Across American cities and in our rural communities, we are seeing 15 or even 20 years difference in life expectancy between different neighborhoods across different zip codes. So, Build Healthy Places Network, I'm not standing here suggesting that all hospitals must become housing developers or that health departments have to plan bus lines. But we are talking about something smarter, using frameworks like vital conditions to catalyze multi-sector action. So get everyone to do what they do best, but as part of the same ecosystem. Because here's the reality, partnerships aren't just nice to have for this addressing root causes of health. They're really essential, because you literally cannot do this work alone across all those sectors, no one institution. And this is true whether you're in downtown Chicago or if you're in rural Montana. The problems look different maybe, but they need coordinated action. That's universal. So who are going to be these new partners? So the 7 vital conditions of health and well-being can provide an exciting roadmap, I think, for shared stewardship. It offers opportunities for coordinated action across sectors and ways that we can steward that. There are certainly challenges in attracting capital for infrastructure, especially in communities that are perpetually left out. So making new strategic partnerships can create more compelling cases for competitive investments that can overcome those capital blocks. And sometimes the smallest investment can create big ripple effects that can be game changers for a community's future. And I think in forming this new way of working, we can also flip the script to listen to what communities know, rather than deciding what they need. So centering community wisdom allows us to let local knowledge really drive those solutions. And in doing so, it creates more positive outcomes. It gets people to participate, that's civic muscle and belonging part, and improves sustainability of our efforts. It's an overall smarter strategy to make things happen. So who are we talking about when we're talking about partnerships to address these drivers of health inequities? So at BHPN, we have created a number of resources, including these playbooks and primers, for healthcare partnerships with community development and with the community development economic sector, and including one focused on rural, and they can be found on our website, which is buildhealthyplaces.org. And this image is taken from our rural playbook, actually, and it just gives a snapshot of the kinds of partners we might be talking about when we're looking at addressing drivers of health. We've got community leaders, people on the ground who know what's happening, local government, the folks with policy levers and zoning power, community development organizations, something that our organization works a lot with. Community development organizations are a natural partner by addressing vital conditions. They work alongside CDFIs, which are community development financial institutions, and they channel capital from a variety of public and private sources, includes the Community Reinvestment Act, and that was federal funding that requires banks to invest in underinvested communities. And they channel these funds into affordable housing, into small business loans, and just basically address a number of those upstream factors. Other partners could be the business sector, and in that diagram we have things like tribal governments, public or private regional colleges. And so this is really just the beginning. This ecosystem is so much wider than just healthcare systems trying to solve everything by themselves. And another thing I like about this is that every single one of those sectors is already holding onto some of the pieces of those vital conditions. The housing authority is already looking at humane housing, local business creating opportunities for wealth. And that's where this opportunity is not always just about convincing people to do new work, but helping them see how their existing work contributes to health and how working together we can maybe improve how everyone performs. So let's focus for a few minutes on the meaningful work and wealth. I'll circle back to that. And we're going to hear a little bit more about this with the panel that's going to follow. And that really meaningful work and adequate wealth, they're fundamental determinants of health, and they operate in multiple pathways. Rethink Health founders of the framework, they've defined this as being well-paying and fulfilling jobs, family and community wealth, as well as the capacity for savings and limited debt. And employment, not only provides income and access to a lot of those things like safe housing and nutritious foods, but it can also be central to social connection, to purpose and a sense of identity, and also crucial for mental and physical well-being. So what we know is that the effects are not distributed equally, but that marginalized communities, underinvested communities, they face systemic barriers to accessing both meaningful employment and sufficient wealth generation. And this could be rural communities, it could be communities of color, just places where decades of underinvestment have left that kind of legacy that we still see. So healthcare institutions are increasingly recognizing their power as anchor institutions. We're going to hear from a couple today to address those root causes by strengthening local economies and creating pathways to prosperity. Often, their healthcare institutions are economic engines in their communities. They're the biggest employers. They can serve as influential role as conveners of other groups that might align, especially when we're listening to what a community has to say. So addressing economic systems is really sort of a natural position as a convener and as a driver of that. Both Healthy Places created a community economic development in partnership with the Community Opportunity Alliance. And we did a playbook, and several sort of pathways emerged as to how these effective partnerships could look. And the collaborations span things like workforce training. I've listed a few here. Workforce training, career pathway programs that connect residents to living wage jobs, support for local entrepreneurs through access to capital or maybe technical assistance, investment when you're creating health facilities, how you think about who you hire for construction and the creation of permanent jobs after that, food sovereignty and health food access, the strategic use of your institutional purchasing power to support local businesses. And really by embedding equity and community voice in the center of these partnerships, I think healthcare institutions have a chance to dismantle the structural barriers that perpetuate both poverty and poor health outcomes in historically marginalized communities. So I'm going to talk for the last few minutes about a couple of examples that we have found in our sort of work and in our production of our playbooks. And these are taken from BHPN's rural playbook that I'm showing, but that can really apply across any geography, some of these. And the first one takes us to New Hampshire, rural New Hampshire. And this story is about two communities, Lebanon and Claremont. Both are rural. Lebanon is an affluent town. It's got one of the state's highest median incomes. Claremont nearby is less affluent with much lower median income. And as a result, Lebanon has wealthy institutions, investments in important community infrastructure. It's actually where Dartmouth Medical sits, which is the only academic medical center in the state, well-funded, has a free bus service. But of course, these communities are in fact connected. So Lebanon, where the medical center resides, has more wealth, but housing there has become unaffordable. So many of Dartmouth's patients also live in Claremont. So for a rural healthcare institution, one of the biggest challenges really can be around retention and recruitment. The other way around, recruitment and retention of workforce, especially when hospital employees can't afford to live in the area. So Dartmouth Medical, as an anchor institution, has made a commitment to community investment as a priority. And it became one of the first partners to collaborate with Southwestern Community Services, which is a community action agency, to create a new bus route connecting the two towns. And the initial investment of $50,000 capital from the community benefits was a catalyst that generated additional and diverse funding needed to ensure this cross-sector partnership supported transportation project. Because the investment was significant because they were always just below the decision line for the state's Department of Transportation. And this is what we mean by anchor institution role. And we'll see some more of that. And as you can see, I've run through some of the vital conditions that were impacted. Obviously there was the transportation sector, the ability to increase access to clinical services, but it also has a role in social connection, and it feeds into economic development and meaningful work and wealth. And as the director of the investment told me, it takes a lot of people to staff a hospital, so they wanted to connect people to where they could afford to live, to where they hoped that they would be able to come and work. So here we are. We've talked about the power of partnerships between health and community development. We've seen where the forces of things like structural racism or policies or practices that have shaped our neighborhoods today, and how the tool like investment with the Community Reinvestment Act can help begin to heal them up. And every person in this room or people watching virtually have the power to become part of a force that changes our approach to what it means to advance health for all Americans. We know there are better ways of creating approaches that work to support and even amplify our efforts to improve health by creating health-supporting environments, collective well-being, and thriving. We've got some more information on our website. I would just say, before I leave, I challenge us all to think about the sphere of influence where we might intersect with someone working in one of these other sectors. See whose organizations are active in your neighborhood or in your field of work. Maybe join a board or invite someone from a community development sector to join your advisory board or the next project that you're working in, get a different perspective. And this morning, I think as we were traveling here today, we were talking about these partnerships do take investment of energy and building of trust between sectors, but the return on investment isn't even just the project you're working on, but it may be a project that you haven't even thought of yet. Or it may be your ability to be nimble and be responsive to a crisis that hasn't come up yet, but that we want to create those cross-sector relationships, really, that are fundamental. So anyway, I've taken up so much time. I'm looking forward to hearing the panel, as I'm sure you are. Thanks for sharing space today.
Thank you so much, Ruth, for that wonderful start to our conversation today. As we now turn to hear from a number of different health systems and other organizations who are working in this space, I am delighted to bring up an incredible panel of speakers. If you'd like to join me on the stage, that would be wonderful, and I'll introduce them as they come up. We'll begin with Dr. Thea James. She is a dear friend and the Vice President of Mission and Associate Chief Medical Officer, as well as the Co-Executive Director of the Health Equity Accelerator at Boston Medical Center. She's a professor of emergency medicine and the director of the Violence Intervention Advocacy Program at BMC. As Vice President of Mission, Dr. James partners with caregivers throughout BMC and coordinates the institution's relationships and strategic alliances with a wide range of local, state, and national organizations and partners across sectors to meet the full spectrum of essentials that enables patients and communities to thrive. Next to Thea, you will see Bridget Lamb, who is the Vice President of Human Resources at Methodist Healthcare Ministries of South Texas, or MHM. It's a faith-based not-for-profit organization that serves 74 counties across South Texas. That's a third of the state, including many rural communities along the Texas-Mexico border. Bridget leads MHM's membership in the Healthcare Anchor Network, advancing the organization's role as an anchor institution by promoting equitable hiring, purchasing, and community investment practices. As part of this work, she leads the Thriving Workforce Task Force, which we'll hear a bit more about, which applies the Vital Conditions Framework to strengthen workforce well-being through initiatives like living wage structure for frontline employees, expanded parental leave, and student loan repayment assistance. Dr. John Rich is next. He is the Harrison I. Staines Director of the Rush BMO Institute for Health Equity. The Institute's mission is to build, evaluate, and sustain scalable approaches to improve health and eliminate health inequities. A general internist by training, Dr. Rich's work has focused on issues of urban violence, trauma, and health inequities. His past roles have included serving as a professor and interim dean of the School of Public Health at Drexel University School of Public Health in Philadelphia, where he also directed the Center for Nonviolence and Social Justice and served as the medical director of the Boston Public Health Commission previously, where he oversaw the commission's initiatives to address chronic diseases. At Rush, Dr. Rich leads efforts to advance health equity by fostering collaborations between the medical center and community organizations through Chicago, some of which we'll also hear about. And rounding out this incredible group of humans is Ms. Ayesha Jaco. She's a lifelong resident of Chicago's Westside and has dedicated her entire career to improving the health and economic vitality of the community that she grew up in. As executive director of Westside United, which was founded by Ascension, Cook County Health, Lurie Children's, Rush, Sinai Chicago, and UI Health, she leads programs and partnerships with additional anchor institutions, including nonprofits and churches, who are working collaboratively to eliminate the life expectancy gap between Black and Brown residents on Chicago's West Side and residents in Chicago's Loop. Under Ayesha's leadership, Westside United has co-created strategies that address social drivers of health, including small business grant programs that have awarded $2.5 million to support the development of more than 175 Westside businesses. Her team has also coordinated $10 million in social impact investing, pooling funds that were put together by the Westside United Hospitals, the American Medical Association, the Illinois Medical District, and Northern Trust to increase access to capital for Westside communities. These loans support affordable housing, community projects, and other economic development projects. So welcome to each of you, and thank you so much for being here with us today. I think to get us started, I'd love to hear from each of you. Just how are you coming into this space today? What's top of mind for you? And yeah, just feel free to share a little bit about how you're coming in. Maybe reflect on what Ruth has shared or whatever you'd like to start the conversation. Thea, maybe we'll start with you.
Yeah, well, I first want to say thank you for the privilege to be here today. It's really an honor to be here with all of you and my esteemed panelists as well, and Emily. And the keynote speaker, thank you. I just want to say, I'm feeling great. I feel excited, motivated, inspired. I mean, I'm an optimist by nature, but honestly, this room feels like there's something kindred going on in this room, and it just feels like a good space to be. And I would say being an optimist is, it's. I don't know, it just feels like it's not unfounded for me. It's been what my experience in life and career has been, so it's great.
Thank you so much.
Yeah.
And I second what you say. I'm excited to be here and thankful for the invitation and opportunity to be with this panel today. The momentum that I'm feeling in South Texas right now, the work that our organization is doing, I'm excited, I'm hopeful that there are great things on the horizon. So I'm excited to talk about that and share that with this group today and see how we can take these things that we're doing in these individual areas and really just spread them across the entire country. So.
When I come into this space, I feel like a moment of relief from the anxiety that I feel on a day-to-day basis. And sometimes in this context, and I hope you'll see where I'm going, I think about my ancestors. So I think about how I got here, and in many ways it was the influence of watching my father practice dentistry as a solo practitioner, taking care of whoever came into his office without worrying about whether they could pay or not. And because he was a solo practitioner, I and my siblings were pressed into service as his assistants along the way. And so we saw this on the day-to-day. And so that sparked something that I think about whenever I'm in the presence of Dr. Thea James, because that's how I felt when I got to Boston City Hospital, that there was a place where people could be cared for without worrying. I mean, it wasn't the most fabulous physical plant that you could find, but I'm reminded of that. And then again, when I came to Rush, I felt that same sense of a mission, that we're here for a purpose, that we have a goal. And so in this room, as I look across the room, I see all of my partners in this work, all of us who are looking for those opportunities to move this forward, to create the partnerships that are going to make the change.
I'd like to plus one everything that everyone has said, including you, John. Also thinking about my father, who left an ethos for me and my siblings. He died prematurely due to conditions related to heart disease. But as children, he was an engineer, an artist, and his mantra was make your community better than you found it. And often we would pass on 290, this expressway right out here, and pass the medical district. And not once did I think that I would be one day in these buildings helping to live out my father's mantra. I also have to point out for those of you that are in Chicago, but this is not home, that we're adjacent to the United Center, where the world-famous Chicago Bulls during maybe 91 through 96 won world champions. But when I look around the room, I see our young brother Marquise, who's a leader in the Garfield Park community, who's going to be a radiologist. Is that right? Okay, we're gonna get there, right? I see Rakia Curvey-Johnson, one of my staff, Elle, Garth Walker, so many champions that deserve a championship ring when we think about the work that we're aspiring to do here in Chicago and beyond in the health equity space. So just honored to be here. It's very refreshing as well.
Thank you all so much again for being here. I'm so excited to dig into this conversation. I have a very easy job today because I just get to drop one question and then y'all are gonna take it from here. Thea, I'd love to start with you, if you don't mind. At Boston Medical Center, whether we're on shift together or whether you're in the boardroom talking to other C-suite leaders, you've been clear that breaking cycles of poverty in the communities that we serve is not separate from healthcare, it's fundamental to it. And that's a real shift in mindset compared to how I think many of us learned about what it means to be a healthcare provider in medical school. Can you talk a little bit about where that perspective comes from and then how you've sort of brought that frame into your work to catalyze some of what BMC is doing?
Right, sure. It was very early that I recognized that, medical school was far short of what we needed, it was designed for something that's highly predictable, and everything is in place like it ought to be. It's designed for learning how to diagnose and treat disease. That's it. That's kind of like where it stops. And so as an ER doctor, you learn things pretty quickly if you're thinking at all. But there's where the issue is, because are you really thinking at all? Because what your question makes me think about, I always wonder if people have, and particularly hospitals like America's Essential Hospitals, which is what my hospital is, and these are hospitals, as you well know, that provide care for patients who come from disinvested communities. So I wonder if people who work in those kind of healthcare systems actually have the mindset, to think that they can actually impact or transform what they see coming through their doors every day. And, my sense is they don't really understand, how these things happened. And so, they don't really feel like there's anything that they can actually do about it, and so they continue to cycle it. On top of that, and if you take it a step back, somebody, when Essential Hospitals, and maybe didn't have that name, that trade name at that time, but somebody decided that these certain hospitals should be like poor hospitals that take care of poor people. And when you have that mindset, you will perpetuate that very thing that you are. I don't think it's in your mind to even think that you can transform it, but that you accept that as your role. And the approach that most people will use for that is charity, which is unfortunate, because charity has its place, but it's definitely not designed for people to someday not need it. And in many cases, it's designed with traps to penalize you if you attempt to take an off-ramp, being constrained about how much income you can earn without losing the housing and that type thing. So it's not, it's not really designed for that. And so I think that what most of us would do, and what I would say to people, is that there is no return on investing in charity exclusively in perpetuity. Not only that, because it's like pouring money in a bucket that has gaping holes in it. And not only that, it is not a great business model. I don't know of businesses or corporations that invest that much money in something that, really has no return. And I think also people are not necessarily able to understand that if you understand the root, and most people don't, the root of what they see, you can address that and create assets, versus other things. And so, when I went to business school, not to learn how to. I didn't want to study health management because I didn't feel like I could learn anything from it, because the curriculum, from what I could see, how it was operating within healthcare systems, it really wasn't achieving anything. I went to business school to try to find a way to make the case for addressing the root. In my mind, I had learned already that the root is economics. Because, you already know who's going to do worse. You don't need to study why that's happening. It's highly predictable, and it's economics. So even after my very first module is where I kind of learned it. I took the straight business model versus the healthcare management model or curriculum, and what I concluded that things stayed the same because we were not proposing our patients with things that were of value. We were not giving them a value proposition. We were proposing to them to come in the context of limited resources, come to all of your appointments, and spend your limited resources on getting on some transportation to go to another neighborhood to find healthy food, pay for co-pays and that type thing. And that is of no value to them. And in fact, it will never work, and they're making rational decisions. And so I felt like, and I'll wrap this up, I'm sorry, but I felt like if we were proposing to them an opportunity to change your life course trajectory, to become stable, to have financial security, and change your life course trajectory for generations, then they could buy into that. And over time, it would impact the aggregate economy in a very, very positive way. So once I sort of understood that, I understood ways in which we could address that, and many of them were already cited by our keynote speaker.
Thank you so much, Thea. Yeah, and I know we'll have time to get into some of the ways that that's happening at BMC as well, I hope. Bridget, I know some of this connects to the work that you have done at Methodist Healthcare Ministries. You've really leaned into that anchor mission model. And so maybe you could speak to some of the specifics and feel free to dig into what you're doing either beyond the walls of the hospitals and the communities you serve, or within in terms of shifting institutional resources that were already available to become more of an anchor mission institution.
Yeah, I am. So, just hearing everything that Thea just said, I love it. So, my organization has been operating for 30 years, serving the same geographical location that we talked about earlier, the 74 counties of South Texas. And we've been doing this work, we just always haven't named it in that way. And in 2021, we really stepped into that and put it in our strategic plan, calling out internal transformation. So not just the work that we're doing in the communities that we serve, but also internally, what does that look like for us? And so that was the anchor strategy work when that started for us in 2021. And I'm going to talk a little bit about some of the external work as well. But externally, we had worked with Dr. Shoma Saha from We in the World, and utilizing the Pathways to Population Health framework developed by them in some of our external work. So in our coalition power shifting work that we were doing, and that's Thriving People, Thriving Places. And so as we were going through that, we thought, how in the world can we do this work where we are trying to create thriving people in thriving places and not have a thriving workforce? And so in 2021, 2022, we started off with just looking at compensation, right? The economic factors that impact that. And we implemented, so Texas, for those of you who don't know, I know many places have minimum wage, state minimum wages. Texas state minimum wage is $7.25 an hour. So just to put that in perspective for everybody. So in 2021, we made an initial attempt and we went to $15 an hour. So this is right off the heels of COVID. We had kept all of our 500 plus team members employed during that time, even though we couldn't be physically there. And then subsequently in 2023, we went to $17 an hour. And then in 2025, in September of this year, we implemented a $21.15 an hour minimum wage. So for our organization. And so I've kind of fast forwarded through the whole thriving workforce. But when we started that thriving workforce work, it was really in 2023. So right then and there, we were at $17 an hour. And we thought we need to do work on what a living wage looks like for our workforce. How do we create that for them? And we took 24 of our team members from across our organization at every level, every ability, and brought them together. And after the first meeting, just having a good 4-hour discussion amongst ourselves, we realized that the living wage just wasn't going to be enough. That just was not going to be enough. And so we employed the vital conditions as the framework that we were going to use to put this together. And so through that, we took 6 months. And so we had these 24 team members, and they broke off into groups, and they created the framework. We met on a weekly basis. So it was not just, it was giving time and resources from their regular jobs as well for them to be able to do this. And then at the end of 2023, we adopted the thriving workforce, as the framework and the vital conditions. And then we set about the task of actually coming up with strategies and solutions. And we surveyed our workforce and said, all right, this is what a thriving workforce, this is what we say a thriving workforce looks like. And are you experiencing any of these things? And so we went through the 7 vital conditions and the framework that the team had put together and asked our own employees, how are you experiencing life? And what we found, we're a healthcare organization. People were struggling being able to pay a copay to go see a doctor, right? We're providing free health care, but our team members couldn't go see a doctor. They were experiencing some level of food insecurity. And what could we do about that? They were experiencing childcare issues. So there were areas that we identified in that late 2023, early 2024 survey. And so we set about doing that work to come up with solutions. And so you had mentioned some of the things that we've done. We implemented parental leave for all of our employees. So 12 weeks of paid leave for the birth of a child, and that in a lot of places that may seem not that spectacular, but I will tell you in Texas, that is not the norm for how we operate as employers. We went student loans. I mean, when the student loan repayment, we implemented a student loan repayment for our frontline workers. It's hard. When you said it's hard to work 2 minimum wage jobs and then go and find healthy food. And so we worked with local vendors to bring in fresh produce markets on a monthly basis So sometimes we offer it free of charge, sometimes they pay at the $10 to $15, but they're walking away with 15 to 20 pounds of fresh produce. And Joe, so it's not always big solutions. I will say that the wages matter. So that is the way that you start that. But there are other things that we can do to support our workforce. And if we're not supporting our workforce, that's part of the Anchor mission, is that transformation from within, and what we're doing to support all of the other work that needs to happen in here. And so there's a lot of things I could talk about, but I know we're gonna.
No, that's wonderful, and that's actually your last sort of finishing point there is a nice bridge, I think, John. You know, you do a lot of work that spans the university, the medical center, and creates that bridge to communities. And so maybe you can share a little bit about how, either in your current role or your past contexts, you've seen strategies work to engage leadership, to mobilize, to create those bridges between institutions that sometimes think they have all the answers, and the communities that they serve.
I think that you ask a really important question, which is, well, how do we engage leadership to identify a goal and to pursue that goal in a tenacious way? And we happen to have here, and what I've seen at Rush, is leaders who are not afraid to name the causes. So we have a CEO in Dr. Latif who will say, the causes of these unacceptable gaps are structural racism, are economic disadvantage, disinvestment from communities, lack of investment in education. So being able to name, having folks who are brave, Dr. David Ansell, shout out to Dr. Ansell today, is one of those people who is going to name the causes. And what that does is to cascade throughout the organization. And we also have leaders on the university side who have been doing this work for decades as well, and are committed to educating the next generation of leaders who are doing this work. So part of it is, what are the commitments that have been made to get us to this point? And charity, this is not charity. This is about an alignment, part of our strategic mission, to ensure that we address this unacceptable 20-year life expectancy gap that exists between downtown communities and communities to the west side and the south side. Now, that's a big goal. And so we also have to articulate and think about, how do we get there? Because even as we presented this to some of our advisors, they said, well, you need some touchstones along the way. Well, we know that one of the major drivers of the life expectancy gap is cardiometabolic disease. And so we are currently undertaking a broad partnership called Live Healthy Chicago. And the image that you showed of the health systems ecosystem is an example of what that coalition looks like. It is a partnership with the AMA. It includes partners from across the entire city coming together with the goal of decreasing atherosclerotic cardiovascular disease risks by 1% in the 27 communities that are most affected. So here, we're focusing now on the causes of the causes, right? Because we have to do both. Anchor mission, which we'll talk about, is a critical part of this, and then some specificity to addressing these problems using technology, using innovation. We've partnered with a company, Nuna, that's created a very impactful technology so that patients who are being treated with hypertension can be engaged in an ongoing way. That has resulted in a dramatic improvement in blood pressure control among people who are previously uncontrolled. And so we need those measurable moments so that we can show our progress towards our larger goal, while continuing to invest in these longer-term investments in community and measuring our progress to make sure that communities have all the assets that are needed to really stimulate and invest in everyone having the chance to be healthy.
No, that's amazing. And again, you're setting this up really easily for me. So I'm going to bridge right over to Ayesha. I mean, your work on the Westside has been instrumental in ensuring that communities get what they need and that communities can say how resources should be used. So can you speak a little bit to how that power dynamic it has shifted? It's not a charity dynamic of here we're going to give you things to do something we think you should fix, but rather giving communities the power to identify what how those resources should be used. Maybe talk about some of the partnerships that are involved in creating that too. That'd be great.
Sure. So on the onset of the foundation or formation of Westside United, it was born out of Rush University Medical Center's Community Health Needs Assessment in 2016 that outlined the life expectancy gap. So if we all got up right now and got on the blue line or the green line trains, we would see a difference from where we are now in the housing stock, the further we go west, the academic school ratings. And so when that table was set, Rush immediately called UI Health, another hospital in the medical district, Sinai Chicago, a little west, Lurie Children's Hospital, Ascension Health, Cook County Health, to think about and to ask and answer the big question, what if? What if we came together, because if combined, they'd be the #1 employer in the state of Illinois, to redirect their hiring goals, where 1% of the workforce would be from Westside zip codes. They also asked, what if we directed a portion of our spend, because we spend $4 billion collectively. So what if we just gave 1% of that back into efforts related to giving supports to local businesses who can join in to the hospital supply chain. So those conversations were happening within our health systems. You heard about the brave leadership here at Rush that really spearheaded the movement of Westside United. But the next piece was to not be a prescriptive model, coming in, telling community what the problem and solutions were, and to be mindful about a co-governance structure from the beginning that weaved community voice at every level. So once that table was set in 2017 and Westside United launched in 2018, there was a planning committee of 16 folks who lived and worked in the West Side that vetted and co-created each strategy in the anchor mission space. So when we talk about our original pillars of economic vitality, thinking about neighborhood and the built environment, thinking about access to care and education, community went into that space to create. They also informed a What We Heard report, which said that they wanted 4 things, community collectively, which here is 10 zip codes, 550,000 people. They said, we want safe neighborhoods, we want jobs, we want equitable access to care, and we want equitable access to education for our young people and meaningful things for them to engage with. So that, along with the launch of that planning committee, that initially became a community advisory council. So 7 years later, that governance structure is still in place. And we also have an executive leadership council where our hospital leaders sit across from community members, and they help guide the work of Westside United. We also have working groups, so when we're talking about making annual commitments and spend, you not only have chief procurement officers, but you have community members in those spaces. You have community members designing small business grant pools. So that's very important to us, and as we look to the future in our new board structure, forthcoming board structure, you will always have that community voice. So it's critical to the work.
No, that's incredible. And it's led to some really sort of innovative and in some ways surprising investments for the hospital. I wonder, and I don't know actually whether you want to speak about this, Ayesha, or John, if you want to speak about this, but if you could share a little bit about the investment in the laundry facility and thinking about how and why a hospital is investing in the creation of a laundry company, that I think would be a helpful example to make it really concrete for folks.
Yeah, we can tag team. So the laundry, and you're from Cleveland, right? So, or working in Cleveland. So we know that the Cleveland Clinic, that model with Evergreen Co-op was something that this collaborative had wanted to replicate here in Chicago. So the work really began in 2017, working with World Business Chicago here, so Civic Arms, thinking about how to co-locate that model. Unfortunately, it stalled a bit, it went away, and it was brought back to life in 2023. And so the idea was we got a call from UI Health, who was working with a local business owner who wanted to resurrect the idea. And the thing was how do we get our systems around a table to think about localizing this industry? Because our systems were outsourcing to neighboring states, Indiana, Wisconsin, and so Westside United worked with our systems partners to project manage the idea, brought in local philanthropy via the Staines Foundation, who were on a similar trajectory. They had just purchased this 60,000 square foot facility, and so it was a beautiful meeting of the minds around the ability of institutions like Rush, Lurie Children's Hospital to say, yes, we will invest. So we, again, localized spend, but it also became a vehicle for local job creation. So we've also had about 100 hires there. 73% of them are from Westside zip codes. So you see Anchor at play under one roof, literally, and now there's talks of additional phases. And so that investment is true to the model of Westside United, but specifically for Rush, I know you all were the first to raise your hands, and you continue to think about innovative ways to localized spend.
Indeed, that's what this is about. If we think about the drivers of the life expectancy gap, we know that unemployment is a major driver. And so here you had, in a community that has, North Lawndale has one of the lower life expectancies at birth, you had an unwanted land use, which in itself, from an environmental perspective, is a detriment to health. And we had the environmental impact of a major hospital system trucking its laundry miles and miles across state lines. And so what do you reap from this? We know that by that economic security, by providing jobs with benefits, with retirement, that you're investing in the community, and by addressing those unwanted land uses, you're also removing some of the stress that comes when people walk past unsafe and unsecure places. The benefit to Rush, of course, was savings of $750,000 per year. And so you have this mutually beneficial bidirectional learning opportunity that is there, and I think it's there in many other places if one is attentive to them and if the work is happening in partnership with community. And so it's the best, and that's a pretty rapid benefit coming back. Not all the benefits will accrue that quickly, but it certainly is an example of how this investment in community may have a direct impact on the life expectancy in a community that really needs that investment.
Oh, that's amazing. Bridget or Thea, does that bring up anything that you want to share kind of in the same vein of work that you've done that either in partnership or that's leading to, in some cases, huge ROI, but perhaps just another concrete example for us?
Yeah, I mean, as I was sitting here listening to both of you, I was thinking, well, this is a playbook. This is a blueprint. I mean, you think of all these people, which is the most irritating thing I ever hear, is when people say you can't boil the ocean. You can't even respond to it. You just go next, or like ask them to move along or whatever. But you guys are like putting this in action, and we are all anchor institutions. And so we really follow that model of the mission of the Healthcare Anchor Network, which is building more inclusive, sustainable local economies by hospitals being intentional about how they hire, invest, and procure. And, we have done some similar things. Actually, we kind of followed you guys, Rush, when you got the Advancing Cities grant from J.P. Morgan Chase and Westside, United grew out of that. But I would say that one of the things that being a safety net or essential hospital, we don't have, line items for things like community benefit dollars. That doesn't exist for us. And so we have to use things that present an opportunity and may not have been designed for that, but we see an opportunity in it. And for example, in Massachusetts, we have this thing called determination of need, that when you build onto your hospital or buy expensive equipment, add more beds, the state requires you to give 5% of the total cost of that to the community. And instead of just writing a check for the community, and the state has to approve whatever you choose, we asked the state if we could invest and we only had like $6.5 million the first time, if we could invest it in housing and small businesses and jobs and things like that, and the state approved it. And not only that, they kind of like really loved it, and now it is like an expectation. It is regulatory that you will do something like that with it. And the benefit is us having just like $6.5 million. Other hospitals in the city, have things like their determinations of needs, and I would say for the last 3 years, one 69 million, one right now 90 million. And we invest together. We sit at tables together. And so more people are able to benefit, from all of that when we all sit down together. And we do our community health needs assessments together now as well. And, we have this hiring thing as well where we had a goal to hire, I think it was 52 people from 6 zip codes in a year. We wound up hiring 1,112 people in like 15 months. And they're all on these, hiring tracks. We invested in, and you know this, Bridget, because you were just there last week, but we invested in something the community said they wanted. And that's how we start everything, is with the community. They know what they need. They know what they want, what it requires for them to transform their lives. We don't. They know. And so we follow them, because not only do you hit the nail on the head the first time, you do it quickly. And so they wanted this grocery store. We took some determination of need money and first invested in some housing. Some of that housing was to own, some to rent these units. And that worked for us because it focused on generational wealth building. But on the bottom level, there was a retail fund there as well. So we invested in this healthy grocery store. The original owners were in Washington, D.C. versus Boston. The pandemic happened and they said they couldn't travel, but they would, again, people thinking they know what's best for people, they would identify local operators for us. The two people they identified were these two black men who are seasoned entrepreneurs. They were not interested in being operators. They wanted to own the business and the physical space to, again, build generational wealth, provide equity stock ownership for their employees. And you saw it. But at any rate, I'm just saying, when you don't have, funds and things like that at your disposal, you just have to be creative and look at what does exist and repurpose it, if you will.
And so building off of that about the community and going to the community, because charity is not a long-term model for sustainability. So we implemented, our coalition building is called Prosperamos Juntos, Thriving Together. So that's what it's named, and the way that it's set up, it requires a minimum of 3 sectors from the community. And the first part of the coalition is the learning phase, because when you bring sectors like healthcare, business, faith communities together, they have to learn how to talk to one another and to communicate, to create these type of programs that are sustainable in a long term. And so MHM has really invested. We've been at this for 4 years. We've had over 50 accepted. We have, I believe, it's somewhere in the 23, 24 that have completed the implementation phase, and in 2026 we'll be moving into some of the sustainability work.
No, that's amazing. There's a lot of synergy across these different geographies. I'm wondering, and John, maybe we'll start with you on this. If you can share your thoughts on what of these strategies are portable? Like what is sort of the model or the framework that can be implemented no matter where you are? versus what needs to be done in very locally specific ways. And I'm starting with you because I know you've moved around to a few of these different cities.
Well, I think the whatever strategy one takes, it should begin with the conversations with the community. There is a kind of local, hyper-local nature of this work, which should begin with assessing, listening, understanding how the community is seeing these health needs. There also, at the same time, can be an assessment of the needs of the institution. That is, what are the regular needs, activities of any organization that are being met in a variety of ways, and can we create a partnership that will allow us to make these mutually beneficial, right? I mean, Fillmore is a good example because it was a need that the institution, all institutions have, which is laundry. How does one can meet that in a variety of ways, but the intentionality about identifying opportunities to have it benefit the local community is that difference maker. And so I don't know that anything is easily transplanted if it's not connected to those intense conversations with community. That's where you could get a kind of square peg in a round hole, where it worked. I think much of innovation is hyperlocal, but the Anchor Network is a way to take and elevate those core principles so that the members can apply them, because I think it's important to have some guiding principles. But I think the innovation space here is large, and the process of gaining that innovation will inevitably need to happen in partnership with community.
Thoughts from others, and Ayesha, you talked about this earlier, about shifting that power balance. I'd love to hear a little bit about how that has worked in practice in healthcare settings, because with Westside United, there is a very well-defined structure and sort of rules, essentially, around how that money gets used. How does that work when you're starting out, especially from a healthcare setting, if you're looking to engage with the community to set these priorities?
So I'll talk a little bit about how we started, and I know we have a short time, but for us, it was hiring and placing people in the communities we wanted to impact. So we didn't all sit in San Antonio and say, we're going to do this work from San Antonio to impact all of South Texas. We hired and engaged community members to be our community connectors to help us do that work. And I think that's been why it has been such an effective model for us, and that we've been able to move. We didn't assume that we knew what we were doing from the High Point in San Antonio. That's our corporate headquarters, but really getting into those communities and being a part of them, hiring people that are part of those communities to do that work.
And I would say it's important to acknowledge the existing genius that community has. What we heard early on from community was create nothing for me without me. And I know what I need. I just need your resources. So is there courage for those resources to be distributed at the beckoning of community? And that's what we've seen when we think about the Sankofa Wellness Village, which is something that will be opening in spring of 2026, co-locating Erie Family Health to provide primary care. Rush will have a Center for Well-Being. Westside United will be headquartered there. Equal Hope. You have the Y. You have a cafe. You have a banking institution in a corridor that has not seen sizable investment of this kind since the 1960s. And that is because of a vision that is seeded of a local pastor who had an idea 30 years ago of anchoring a wellness village in the historic Madison corridor. So what you see are systems like Rush, Erie, the YMCA rolling up their sleeves to invest in an asset that they don't own, right? And so community owns the asset. So that's an innovative model, and that's due to the listening of what community said. We know what we need. We just need a financial roadmap. We need investment. We need your partnership. And so that does take bravery, and I would say that it also takes constant netting and constant just generation of that communal space for trust, because you're going to always have to build that and sustain that. And I feel like it will continue to manifest itself, but it does take that investment of people power, financial investment over time for community to see that. And then I'll also say, lastly, local philanthropy. So that was born out of the Pritzker-Trauberts Foundation's ability to say they will deliver a $10 million prize for a capital investment in the South and West Sides. When we think about the linen, that is the Staines Family Foundation saying, we will fund this. We believe in this outright. So it goes back to that multi-sectored in the wheel that we saw in the keynote, where you have those different factions being activated. It's great to see it come into be, but it is rooted in that community partnership.
Oh, that's amazing. I think there's so much more we could talk about. We are coming close to the end of our time together this afternoon. And we've touched a little bit on this, but I'd love to hear from each of you. You know, if you could leave the folks who are listening, and it's certainly many more than the folks just in this room, with one actionable strategy, something that you would ask them to do, either as an individual or through their institution. Would love to hear your thoughts on what feels most important or catalytic for folks to do as a result of this conversation. Thea, can I start with you?
I would just say one thing. I almost feel like it doesn't need to be said to this crowd, because I mean, you guys are so far ahead, and but I would just say challenge convention. Just challenge convention. If you don't see, what you want to see and what should be there and what you imagine, you just do it. If something is generally done a certain way, change it. Do something different. And you have leadership here, so you guys have no excuses, right? Because you've got the right leadership here. So that's what I would say.
I would say don't overlook your workforce. That is the means by which the work is accomplished. They are important, and oftentimes you don't know how they are experiencing life in a way that's so similar to the work that we're doing. And so just don't forget about them in the midst of doing all of this good work.
Two things. The first would be to name the causes. If there's pressure not to be specific about the causes, resist that pressure, because unless we name what we are trying to affect, and I think that's a strength of Westside United, naming what is and what we want to change, then the work can get diffuse in a way that's not helpful. And then I would say, find a partner, maybe an unlikely partner. What you've heard, I think, today is that relationships and partnerships are critical to drive this work. No institution can do this alone. And institutions that try to do it alone, I think, have a high chance of getting it wrong. And so I hear that, and it's reinforced as I listen to my colleagues today.
Thanks. Ayesha?
It's not enough to put a seat at the table for the people that you're looking to serve. They have to help build the table. So make sure you're putting them in at the beginning, phase 0, the people that you want to be impacted by your work. They're also architects.
It's amazing. Thank you all so very much for joining us here today. As we close out, I think, I'm going to switch over the microphones. There's just a tremendous amount of wisdom in this room and a tremendous amount of experience in this room. So thank you for sharing a little bit of that with us today. As we close, I do also want to acknowledge all the folks who are listening in from around the world. Thank you for joining us. Thank you to everybody who's here in the room with us. Also want to thank our ASL interpreter as well as our graphic recorder for their work during this event, and to the entire production team who's behind the scenes on both the program side and the event production side. Thank you all for making this event come to life. As I mentioned, there is free CE and CME if you're a healthcare professional and you've joined this conversation. We'll send out the link via email for you to claim that. And we would also love your feedback. So you can use this QR code here to complete a very brief post-event survey. And we'll also send that out to you via email after the event. And thank you again very much for joining us here today for the National Health Equity Grand Rounds.